Hello class. In this unit we will be going over abdomen protocols. In class we're going to be going over each organ individually. You're going to learn to scan each organ individually. The goal is to put them all together. Very rarely are you asked to just scan a gallbladder or just scan a liver, though there are exceptions to that rule. Over 90% of the time what you will be doing is scanning either what's called an abdomen complete or an abdomen limited. So the eventual goal is to put them all together so that you can perform those sonographic studies. Most of the general facts we have already gone over, so this is more of just a review for you. But I wanted to touch on the NPO, which is something that we do for abdomens. The main purpose, as stated in the slide, is so that it reduces the amount of gas a patient might have after they eat, and also when a person eats, the gallbladder empties, so that it can help in the digestive systems. By keeping them NPO, it allows the gallbladder to fill so that we can see it. The typical rule is 6 hours, or if they're a scheduled patient, like an outpatient, we just tell them not to have anything to eat or drink after midnight, and then schedule them for in the morning sometime. If you're doing a patient from the emergency room, obviously you're not going to have them sit for 6 hours. You're going to scan them and hope for the best. What you need to realize is a lot of times people will say to you, well, I only had a bite. The body doesn't know that you're having just one bite versus a whole meal. Once you start eating and there's food in the stomach, it goes into digestive mode, and part of digestive mode is for bile to go into the duodenum to help with the digestion. Now for some patients you'll find that they've ate and you can see their gallbladder just fine, and on other patients they might have a little bit and you not see the gallbladder at all. It's a chance we take, and everybody's body works a little bit differently. As we scan the liver, not only are we going transverse and longitudinal to the organ itself, we have to remember how it sits in our body, and our diaphragm is curved. It is not straight up and down. So our liver fits up into that curve of the diaphragm. So as we're scanning in longitudinal and transverse, we're also angling superiorly so that our ultrasound beam is perpendicular to the organ itself. And remember, we want to try and be perpendicular to our organs because that's where we're going to get our strongest return of echoes to the transducers and our better images. We're going to start with our longitudinal liver images. Now, as you see, there's only 7 on there. Just remember that as you're scanning along, you'll be taking more images than what you see on the screen. This represents the minimal pictures that are required in order for the test to be considered a valid exam. These are the anatomy that you want to have documented on your pictures so that whoever is looking at the images knows where they are. And they know you're in the left lobe because they see the aorta, or they know they're in the right lobe because they see the main lobar fissure. So these are the minimal requirements. We're going to start with our longitudinal views of the liver, and I've started with the left lobe, picture number 1. There will be corresponding CAT scans with a line going through, which is going to correlate to the image that you see. If you look at that CAT scan, your line is going through the left lobe of the liver. You can see that it's to the left of the midline, and it looks like a small part of the left lobe, which is normal. Now there are variants to every piece of anatomy that we are going to scan. The picture on the right of that left lobe of the liver is fairly large. So one might say, well, how do I know that's the left lobe? You can't really say, well, because the sonographer wrote left lobe, because maybe she made a mistake. So that's where knowledge of normal anatomy becomes important. Any radiologist looking at this is going to know that that's the left lobe. Image 2 and 3 are showing you the aorta, and then on 3 the corresponding caudate lobe with the ligament venosum. If you look on the CAT scan image below, you'll notice that the line for the aorta is to the left of the midline. The midline would be right through the middle of the spine. Third image, which is also the left lobe, it includes a caudate lobe, which is posterior to the left lobe of the liver, and the ligament venosum, which is that very echogenic structure actually between the left lobe of the liver and the caudate lobe. I'm hoping you're grasping here is that I'm talking about the left lobe of the liver, but we are now technically on the right side of the patient's body. Again, when we are scanning and we're talking about structures, it's organ specific. The left lobe of the liver will extend into the right side of a patient's body, or the right side of the midline. Image 4 showing you the left lobe of the liver with the IVC, which is that large anechoic structure. You can see an hepatic vein draining down into the IVC. You can also see the caudate lobe anterior to the IVC and the ligament venosum. So on some patients you can see all that very nicely in one picture, and on others you can't. You'd have a separate picture for the caudate lobe with the ligament venosum and one for the IVC. From there you'll keep scanning laterally, so that would be towards the patient's right side, and you'll come to the main lobar fissure, the portal vein, the gallbladder. Now this is going to look different on everybody, and depending on where the gallbladder lies on the patient's body, you will not always get all of them on the same picture either. Main lobar fissure is an attachment between the portal vein and the gallbladder. On some people it's short. The image with the red arrows pointing to the gallbladder, that patient has a short fissure. The image below has a much longer fissure, and you can appreciate it a lot better on that image. And again, the corresponding images of the CAT scan showing you approximately where you're scanning in the patient's body. Image 6 is showing the kidney and the right lobe of the liver together, and this is done for a few reasons. One is it shows the comparison size of the organs together. It also compares the echogenicity of the two organs, and that helps when we're determining disease processes. 7 is for the dome of the liver. Now, I didn't put an arrow anywhere on the corresponding CAT scan because it kind of depends on where you can actually get your best image. And if you notice on the image number 6, you don't really see that very anterior superior part of the liver. The liver is a big organ, so you're not going to catch everything at once. But we want to get up there in what we call the dome of the liver. So you're going to angle your transducer very superiorly so that you catch that upper corner of the liver, and that's what the dome of the liver image comprises of. So it kind of depends on wherever you get it the best. There isn't any one standard spot for you to do this image. As we scan the transverse liver, you'll see how very rarely are we transverse to the patient's body per se, but we're transverse to the organ. So now when we do the left lobe of the liver, we're really going to be putting our transducer midline on the patient's body, angling superiorly so that we catch the body. Remember, it's in a curve of the diaphragm, so we want to be angling so we're perpendicular. So we're going to be angling superiorly, and we're going to be pointing towards the patient's left shoulder. And that's our best way to get this left lobe of the liver all the way on the tip. The second picture is a little bit less of an angle so that we get more of the left lobe that goes towards the right lobe. And the landmark for that is something called the ligament teres, and I put an arrow on that. It's a very echogenic structure. It is sometimes so echogenic that it actually shadows like a stone. Our next pictures, we are going to take our transducer, still kind of center it to the midline of the patient, and then angle now towards the right shoulder superiorly. That will get us our image number 3, which is the hepatic veins. And we want to see them as they drain into the IVC. That tells us that we're in the superior right lobe of the liver. From there, we'll start sliding our transducer to the right and inferiorly, and the next landmark that's important for us is the portal vein. Because the gallbladder is a small organ, it's relatively easy to image once you get the right location, the right lay of the gallbladder. So that's really the most challenging part for everyone, because it is going to be different on everybody. It depends a lot on patient body habitus as to whether it lays straight or it's more oblique or it angles towards the medial side or the lateral side. But once we get that, you're going to basically do 3 longs, 3 trans. As you scan through the gallbladder, you're just going to take a few pictures. You're going to measure the wall of the gallbladder, and the organ. This organ is the one structure that you image in 2 planes. We always turn the patient up either oblique, halfway up, or all the way up in a lateral decubitus, maybe even sit them up depending on what we're trying to achieve on our images, and then take the same images in that position that we took supine. The picture that I'm showing you, they're making a lot of measurements of the gallbladder. We don't typically measure the gallbladder at all. If a gallbladder seems exceptionally large, we'll measure the length of the gallbladder, and we measure the wall of the gallbladder. On the image on the right, they're actually measuring the posterior wall of the gallbladder. That is not where you measure the gallbladder. It is always the anterior wall of the gallbladder, and most of the time you want to do it in the transverse view. The pancreas is one of our more challenging organs to image in the abdomen, and that's because it's surrounded by a lot of bowel, so it makes it a little bit more difficult for us. This is where anatomy becomes very important, because we want to make sure that we are scanning in the correct area even if we do not see the anatomy that well. So I want you to look at the picture, the next picture, and really look at the surrounding anatomy. Because the pancreas lays across the abdomen versus superior to inferiorly, when you are scanning in transverse, you are scanning longitudinally of the gallbladder, and when you're scanning longitudinally, you are transverse to the pancreas. Again, we'll go over a lot of this in class. This is one of the organs it's easier to do and explain than to look at a lot of pictures and try to figure out where the anatomy is. So we'll go over a lot of this in class. Kidneys is another organ that is relatively easy to remember protocol because the organ is compact. Once you get a good view of the kidney, you're going to take sequential images from medial to lateral in the longitudinal plane. You'll then turn transverse on your kidney and go from superior to inferior, making sure that you cover and scan through the whole kidney. So you don't necessarily take a picture of every single part of the kidney, but you have to make sure that you scan through it. The challenging part is getting that good longitudinal image to start from and then to scan from. So the right kidney, a lot of times because you have the liver as a wood note, it's not that difficult to do. The left can be a little bit more challenging. Usually we'll scan with the patient on a decubitus with them laying on the right side, have their arm up over their head to help separate the ribs, and don't forget to have your patient take in a deep breath. A lot of times we don't do that, and you'll see a lot of the sonographers scanning and not have the patient take in a deep breath. Well, part of it is as you get more experience, it's much easier to scan between the ribs and get the pictures that you want. As beginning sonographers, it's not going to be as easy for you. If you have the patient take in a deep breath, it pushes the diaphragm down and in turn pushes the organs in the abdomen further down so that you don't have to fight with the ribs. Your kidneys and other organs in the abdomen will now be below the level of the ribs and make it much easier access for you to scan. The spleen up in the left upper quadrant is an exam that you might do in and of itself. They might order just a spleen. The biggest reason we do that is to look for splenomegaly, which is an enlarged spleen, or as part of a complete abdomen if that's the way it's ordered. So the spleen is very similar in texture to that of the liver. If you are just doing the spleen by itself, you don't need to have the patient NPO or patient. Protocol is very easy. Once you find the organ, which again is the more difficult part because it can be up relatively high in the left upper quadrant, you are typically scanning through the ribs on the left side. You just do a longitudinal going from medial to lateral, usually 3 or 4 pictures, and then transverse from superior to inferior. And again, since a lot of times we're doing it to look for an enlarged spleen, the measurement of the spleen become a very important part of the protocol. Abbreviations are something you'll see a lot of in the medical field, and so it's important to understand what a lot of them are. I can tell you my little story when I was in x-ray school, and of course you do a lot of chest x-rays, and a lot of times it would have on their SOB, and I'm thinking, are they trying to tell us that this is not a nice patient and they don't want to come out and say what kind of person they are, but this is their way of saying it? I mean, I didn't realize that it meant short of breath, and that's usually the reason why you do chest x-rays. So it's important that you know a lot of the common abbreviations. So I'll be putting some of this and some medical terminology in here for you to become familiar with what we are going to use most in ultrasound. Medical prefixes and suffixes are important to know because it'll help you understand the meanings of the words. There are lots and lots of medical words and terminologies, but if you have a lot of the basic ones down, you can figure out what it is they're talking about. Peri means surrounding, so if they're talking about pericardial infusion, fluid around the heart. Retro means behind, and so if they say there's a retroperitoneal bleed, well, we know that's behind the peritoneum. Inter means between, and we talk about intercostally scanning, so that means we're scanning between the ribs. If we're talking about itis, that means inflammation. So whenever we hear them talk about endometriitis, well, we know that means there's an infection. Megaly means enlarge. Oma, you hear lipoma. Well, that oma means a tumor. Lipo is fat, so that's a fatty tumor. So they all become important.